Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, and this is Cardiology Lecture Series. And all our programs are video streamed through YouTube. And please do subscribe to our YouTube channel. Now, the feature presentation. In this presentation, we are going to learn something about asystole algorithm. Let's look at some of the objectives for this presentation. We are going to look at what causes asystole. In most cases, asystole results from massive myocardial damage or a severe trauma to the chest, shock resulting from severe bleeding. It can also be related to severe congestive heart failure with poor left ventricular function, and of course the 5 H and 5 T's that we need to be considering in every patient with asystole. How do we identify asystole? There are some things that we need to make sure that are covered before we can definitively say we are dealing with a case of an asystole. We're going to determine what treatment options are available. Then we're going to look at what the outcomes are. When everything else fails, what else can we do? When do we call it stop? So let's continue. Here is an example of an asystole. Asystole is defined as no definite electrical activity on the EKG monitor. Sometimes we may just see a flat line. Sometimes we may just see some wiggly lines like this with no discernible atrial or ventricular deflections. Whenever we see a straight flat line, we always want to make sure that the electrodes are not displaced. We also want to make sure that we are not missing a fine ventricular fibrillation that may be amenable to defibrillation. And another important thing that we need to keep in mind is that the monitor gain is properly turned up. For example, the normal monitor gain should be like this, measuring 1 centimeters. But if your monitor gain is like this, you may want to increase the gain so that it matches the normal electrical activity we see on a surface electrocardiogram. Once we have ascertained that the rhythm is like a flat line, then what do we do next? As I mentioned to you earlier, we need to look at 5H representing hypovolemia, hypoxia, hydrogen ion excess or acidosis, hyper or hypokalemia or hypothermia. On the other side, we have to look at 5 T's like here, namely toxins, tamponade, tension pneumothorax, thrombosis, and trauma, which I mentioned earlier. The thrombosis can be in the coronary arteries or it could be a massive pulmonary embolus. Okay, how do we manage patients with asystole? The options are very limited because of the underlying advanced cardiovascular problems or major trauma to the chest. But nonetheless, we can take certain steps, see if we can restore the normal rhythm. The first and the foremost thing is to provide high performance CPR, 100 chest compressions. This is followed by epinephrine 1 milligram IV push every 3 to 5 minutes. Then we continue the CPR for another 2 minutes. Just pause less than 10 seconds to check the pulse. Then we resume CPR again, followed by epinephrine. If this attempt results in like fine ventricular fibrillation or coarse ventricular fibrillation, and if the rhythm appears to be shockable, then we deliver 200 joules of biphasic shock, followed by continuous CPR for 2 minutes. And this allows us some time to get some advanced airway and capnography. Then we'll continue with the CPR. Again, administer epinephrine as indicated. Then if there is evidence of a ventricular arrhythmia, they can be treated with amiodarone. If you are successful in establishing a rhythm, then we need to focus on blood pressure, volume, oxygen level, and mental condition. If there's no response, I guess it's time to call it quit. Ladies and gentlemen, that's in a nutshell about dealing with asystole algorithm. I hope this has been useful to you, and please do subscribe to our YouTube channel, and also please watch all other videos on Acls lecture series. Thank you so much for watching our program, and please do subscribe to our YouTube channel. If you would like to support this program, you can look for the $sign on the right hand side of your browser and support in any way you possibly can. Again, thank you so much for watching this presentation, and until next time, I am Dr. Nik Nikam.